We're so excited to have you here joining us for this very, very urgent and important conversation. My name is Evan Cutts. I'm the content editor for Color Magazine, and today I'll be serving as your MC. As we get our event ball rolling here, want to just plug Black Mental Health Alliance on social media. Please follow them to stay up to date with all the health news that you'll need to stay abreast of the COVID-19 vaccine, as well as your own mental health. You can also find Color Magazine at colormagazine.com and at our social media handles on Facebook, Instagram, LinkedIn, and Twitter, where we're sharing content and news very urgent to professionals of color. So please follow us and check out what we have going on for you there. Before we get into our very, very important discussion today, we're going to have a few opening remarks and some housekeeping rules. So we'd like to ask you all to please be present, try to avoid distractions. Also note that this meeting will be recorded and shared, so you'll be able to view it, and if there's any information that you need or missed or want to take some notes on, you'll be able to access it after the event. Also note that this event is interactive, so please talk to each other, hang out in the chat, share your thoughts and reactions. And if you have any questions, you can use the Q&A function at the bottom of your Zoom panel there next to the chat button to ask a few questions to our panelists. At the end of the event, there will be a Q&A section where our incredible moderator, Barbara Morse, will be fielding some of your questions to our panelists. And now I would like to bring to the virtual stage the fearless leader of Color Magazine, Camilla Avant, the director of our diversity program.
Thank you, Evan. Good afternoon, everyone. I'm glad you could be here to join us for this important conversation. Color Magazine continues its mission to empower and address issues that impact our Black and Brown communities. It's a great pleasure that we partner with the Black Mental Health Alliance to bring you this webinar today. We find ourselves at a critical point in combating the COVID-19 pandemic. Over the past few months, research shows there has been an uptick in the intention for Americans to get vaccinated. And while this is positive news, there are some communities that may not automatically embrace or feel at ease over this announcement of a population-wide mass vaccination program. Some recent research numbers from Pew Research, a survey that was done, said while about 60% of Americans say they will definitely or probably get a COVID-19 vaccine, only about 42% of Blacks would do so. Compare that to 83% of Asians, 63% of Latinx, and 61% of white adults. So, from the Tuskegee experiments, one of the most disturbing parts of American medical history, to the economic and cultural inequities in the US healthcare system where Black communities are disproportionately harmed, there are very real reasons why some people might be skeptic and fearful of this new vaccine. So strategic messaging and information is needed to overcome this mistrust. Public health leaders express the need for community leaders to work with them, to amplify the voices of people of color, to ease their fears, build trust, disseminate proper information about the vaccine. We are thankful for all of our expert speakers who are here today, who will share their knowledge with you. I would like to now introduce our partner, Andrea Brown, Executive Director of the Black Mental Health Alliance. Andrea.
Thank you so much. It is a great pleasure to be here and to have partnered with Color on this. And so I thank you for the dialogue. I thank you that we are unapologetic and unafraid about what will come out of this discussion, but more importantly about how we meet the needs of our community. I am Andrea Brown, Executive Director for the Black Mental Health Alliance. And for those of you who don't know, we have been in the community almost 40 years, educating Black and Brown people on the dangers of mental health and well-being, and more importantly, the critical importance of mental health and well-being. And today we find ourselves at a crossroad. My partner talked about the pandemic, but quite frankly, there's much that we are juggling as people of color. Between the twin pandemics, heightened racism, and again, the coronavirus. And so I won't bore you with the statistics again. She shared that. I think that it's important. but more importantly, there are people dying that look like us. And we need to figure out, how do we help? How do we message? And what we need to do next. And so it gives me great pleasure as we have this open dialogue. You are home. And so I'm hoping that you engage in the chat with us. I'm hoping that you ask of the experts the questions that we sit around the dining room table talking about. And I think it is important that we call out the truth, even when it hurts. And so today we will do that. We'll talk about the disparities and the inequity and in the rollout of the vaccine, in the messaging of the vaccine. And then we'll talk about those things that make us nervous. Is this an experiment all over again? But let's have the conversation. So again, we welcome you, we thank you, and look for us, because this is, you will see us partnering more. And this is just the beginning as we figure out what the real road to recovery looks like for Black and Brown people. So having said all of this, I'd like to, we had invited another fearless leader, and that would be Derrick Johnson, President Johnson from the National Association for the Advancement of Colored People. And while he was unable to attend because of a scheduling conflict, he has left us with this message. And so be still, and the next voice you will hear after his is that of Evan, who will introduce our moderator. Thank you.
I'm Derrick Johnson, President and CEO of the NAACP. I want to congratulate the Black Mental Health Alliance and Color Magazine for convening this important conversation. It is important for us as African Americans to understand our options in the midst of this global pandemic. For African Americans, we know also well how our government and other corporate interests have not always been forthcoming with information for us. However, it is also important for us to understand the impact this pandemic is having on our community. And that's why for the NAACP, we are promoting education to ensure that everyone understands what options are actually on the table. That we're so pleased that finally we have matriculated to a level where not only are we at NIH and inventing and responding to the vaccine that's on the table, but we're also navigating in spaces so that we can have the proper checks and balances in place. For African Americans, we also understand the importance of mental health in this moment. With all of the rays of despair and misinformation coming at our community, these type of conversations allow us to sift through what is fact and what is fiction. For at this moment, we must stand together, as Naim Akbar would say, with our collective consciousness and make good decisions to keep ourselves healthy, to keep our families healthy, and to heal our communities. Thank you for convening this conversation, and we stand ready to partner at your call.
I know Derrick can't be here with us today, but I am greatly thankful for his messaging and his willingness to share a few words of wisdom with us today. And I'm equally thrilled to have Barbara Morse, health check reporter and news anchor for NBC 10 News, moderating our panel discussion. She is a seasoned expert in medical journalism and reporting, and will have so much to offer to our very, very important conversation today. So without further ado, let's get our panel discussion started, and welcome to the virtual stage, Barbara Morse.
Good afternoon, everyone. Can you see me? Hi, everyone. Yes. Good, thank you. Yes, my name is Barbara. I am so honored to be moderating this today. It's a very important topic. You know, we talk a lot about our history, and we are here because of our history. So we must talk about where we've been in order to go forward. We know that this pandemic has shed a light on, you know, disproportionate or disparities within our community. The Black Lives Matter has done that as well. I was listening to a statistic the other day, and I hate using them. I'm just going to use it this one time. There are 13% of Americans are Black. 6% have gotten the vaccine. We have a problem in this country. And I'd like to introduce our panelists, and I'm going to introduce one at a time. They can tell a little bit about themselves, And then we really need to hit the ground running because we have a lot of stuff to unwrap today. We're going to start with Dr. Melissa Clarke, a Harvard-educated physician for over 20 years. Dr. Clarke.
Good afternoon. Thank you for having me be here. I need to ask them to open my video up. Great, thank you. Hello. So I'm an emergency medicine physician by training, but I'm in a field called population health that talks about the accountability that the healthcare system has for not just seeing patients, but ensuring that all people have the best possible health outcomes. I'm all about being a patient advocate for my patients and empowering them with information. I've been part of and co-founder of an organization called the Black Coalition Against COVID-19 that's been doing work to get this message out around COVID-19 prevention and vaccines since last August, actually. So I'm happy to be here. Thank you.
Dr. Clarke, thank you. We have Dr. Alden Landry, who is an assistant professor of emergency medicine physician at Beth Israel Deaconess Medical Center in Boston.
Good afternoon, everyone, or good morning for the rest of you who are not in East Coast time. I want to say thank you to Color Magazine for hosting me and having me be a part of this discussion. As mentioned, I'm an emergency medicine physician. I also serve as the Assistant Dean for Diversity, Inclusion, and Community Partnership at Harvard Medical School. What I can tell you is from a frontline healthcare worker, from someone who was working in the emergency department at the time of the pandemic, it was painfully obvious to see that the disparities were playing out very early on with this disparity when this pandemic started to happen back in March and April of 2020. And unfortunately, we're still seeing our communities of color, our Black and Latinx patients coming in at higher volumes with COVID-19 and still having the negative sequelae of the disease. And also we're starting to see this bear out in who gets the vaccine. And I'm excited to be a part of this discussion here with this wonderful panel.
Thank you, Dr. Landry. We now have Dr. Cameron Matthews, Assistant Undersecretary for Health for Clinical Services, Chief Medical Officer of the Veterans Health Administration. Dr. Matthews.
Hi, good afternoon. Thank you so much for allowing me to join this conversation. I'm definitely here speaking on behalf of veterans and our nationwide staff of the VA and a lot of the really large lift that we've all done together to address this pandemic. But even more so, I'm a physician myself. I'm a family physician, very proud primary care physician, and I am just personally very much invested in making sure not only do we address a lot of the acute needs of our communities with regard to responding to COVID, but I'm also interested in kind of the long-term effects. So not just protecting ourselves through the vaccine, but how this disease is actually going to affect us both physically, mentally, as well as economically. I think that's something we really need to address, particularly if we aren't looking for solutions on how we're really going to protect ourselves within our community. I think we'll continue to see the long-term effects of that for years to come. So I'm excited for this conversation. Thank you.
Thank you so much. And our final panelist is Carmen Watkins, Interim Vice President of the NAACP. Carmen.
Well, thank you so much. Actually, Senior Vice President of Field and Membership, and just real thrilled to be here today. Over 25 years of outreach and service to hard to serve populations throughout the country. And we support and train over our 2,000 units across the country and create training and opportunities for them to engage in their local communities. We also support the development of leadership through our Next Gen and Youth and College programming, ensuring that we have legacy to this association of over 112 years. And so this discussion about COVID and this pandemic is certainly something that is near and dear to our hearts and something that we know that we have to be a part of as we ensure the safety of our local communities.
Okay, thank you so much, Carmen. We're here to talk about a lot of things, but we're going to start off with vaccine hesitancy. And I think we need to take a look back before we can take a look forward. Most people, if not all people, have heard about the Tuskegee syphilis experiment, which was egregious. You know, we know about Henrietta Lacks. We know about maybe not so many people know about Dr. Sims, who is considered the grandfather of OBGYN, who experimented on young Black female slaves. We have a history of being lied to. So how do we try and use that history to move forward? And what do we learn from that history?
I think it's really important to know that history. As Black people in the United States, we have survived and been resilient because we understand the challenges that we are up against, and we have had to learn who to trust and who not to trust. I would also add to that list of egregious medical abuses, the forced sterilization of women in North Carolina from the 1920s to the 1940s. One of the things, though, that I talk about in many of the talks that I give is that people try to draw equivalency between the Tuskegee syphilis study, which was the withholding of life-saving penicillin to African-American men who had syphilis without their knowledge, to drawing it comparison to the COVID vaccine, which is we're not trying to, treatment is not being withheld, it's actually trying to be offered. And one of the things I also say too is one of the ways that we as Black people have survived too is by moving beyond fear and being pragmatic in the moment and understanding when we're presented with a new set of facts, being able to adapt to that new set of facts and make decisions that will save the lives of ourselves and our families and our community. And we are in such a moment right now. And it's also important to know as well that we have agency in the development of the vaccine, in the approval of the vaccine, in terms of people from our organizations and from our community being at the table and being leads in the development of the vaccine.
There's one other thing, if I could add, is this. I mean, I like the pragmatic approach. In historically, we were singled out for testing or for lack of treatment. In this case, even today, we see that our white counterparts are getting this vaccine 2-to-1 over African Americans, 3-to-1 over Latinx. And so this is not an exclusionary moment. This is a moment where if we even look at the facts, and I know we said we didn't want to do a lot of this, quite frankly, our white counterparts were 30% less likely to wear masks, therefore moving the pandemic forward, this disease forward, but 2-to-1 getting the vaccine. So this is not a moment where we should live in fear. If we just look at the facts as an opportunity, we are not exclusionary in this opportunity. This is being given across the board. There is distrust, not only in our government, but in our medical system. And we have to acknowledge that, but we have to work around it with real information.
And I do want to correct myself. I was called out on this, and rightfully so. We were enslaved. We were forced into slavery. So I just want to make that correction. Because I was called out on that, and rightfully so. So what do we do given this history? I mean, the Tuskegee experiment didn't end until 1972, and that's only because it came to light. It could have still been going on.
I think it really, really makes a difference when leaders like those of us on the Zoom today, and there's so many different organizations and community members around the country that are taking part in the conversation, and that we're not just taking part, but we're also directing it. We are the ones really communicating with our own community and addressing their fears, addressing their trust. We are the ones hopefully holding other leaders in the healthcare system and the government accountable for addressing inequities. I think, my favorite phrase lately is nothing for or about us without us. And we need to be at the lead having this conversation. We need to be the ones answering the questions. We need to be the ones starting the clinical trials and teaching the healthcare workforce and actually coming up with the solution so that not only will our communities trust them more, but that actually the questions that are really impacting our communities are going to be answered.
And that's the problem, us taking part in clinical trials. We're not doing it by and large.
Well, I think I think there's more, a little bit more to the discussion that I would like to just try and hammer home. And, you know, we always talk about the distrust, and it's the better way to phrase is has medicine earned the trust of our communities after so many atrocities? And we talk about the big ones, right? We talk about the forced sterilizations. We talk about the abuse of enslaved individuals. We talk about the Tuskegee syphilis study, but we don't necessarily get into what happened on a smaller level, something that a family member may have experienced within the healthcare system, or how someone may have died prematurely in the hospital, and there was lots of questions that went unanswered. And we historically in medicine haven't earned the trust of those individuals who should be seeking care from us, or who choose not to seek care from us because they don't feel comfortable and safe when they enter into our doors, and they don't feel comfortable being a part of a study, not necessarily understanding the complexities that go along with this and the regulations that are in place, but they have those real world and those personal experiences that they are carrying with them as a part of the trauma that they have experienced in relation to the healthcare system.
Well, we know there was a doctor study that came out a few years ago that talked about these disparities. Doctors admit they probably don't treat Black and brown people the same as they do Caucasians. They admitted to this. It's something, inherent bias is what it's called.
That's correct. And it's been more than one study. It's multiple studies in terms of how African Americans and Latinos don't get referred for life-saving treatments such as dialysis or transplantation or heart catheterization, which is the procedure when you're having a heart attack to open up your arteries and allow blood to flow, or even something simple as getting the right amount of pain medicine if you're in pain. And so, you know, it's not, as Dr. Landry said, it's not just the historic abuses, it is people's everyday experience with the healthcare system. And with the question, you know, we talk about, do Black lives matter? Do Black and brown lives matter within the healthcare system? And sometimes, unfortunately, we see that they are devalued just as they are in many other segments of society. And that's where the advocacy comes in. I mentioned, I wrote a book called Excuse Me, Doctor, I've Got What? Taking Ownership of Your Health. And the whole reason I wrote that was to give people a roadmap, a way to interact with the healthcare system in a way that they're empowered, because that's so important. And so with the questions around the vaccine, I applaud our community for asking the questions. It's the conclusions that we really need to focus on.
So what do we do? How do we approach this with patients? How do we get out into the community, more importantly, at large? A lot of us had to work through the pandemic in, you know, jobs, you know, that weren't that great, minimum wage jobs. We didn't get the healthcare we needed. We do have mental health issues as a result. There are so many, I think there's layer upon layer during this pandemic, and it has exposed all of these layers. So where do we even begin to start peeling that onion?
I know for the association, for the NAACP, certainly, we have to have a dual tracked conversation. One is about information and providing the best possible information that we can to the community about the vaccine through doctors like we have on this panel today, and then allowing people to make a choice. The next discussion is about the distribution and access. It's the distribution of the vaccine and the access to the vaccine. I think you're right. For many during this pandemic, they were frontline workers, they were low wage workers. And so the ability to schedule an appointment on Wednesday for the following Wednesday is a big deal, because I may not get my schedule until Saturday. So committing even to that level is a lot. I know personally, trying to get an appointment for my mother, I worked 2 computers and my phone. First, I had 2 computers and my phone. Let's start there to try to get my 92-year-old mother a vaccine. And then made a couple of calls, which is about class and access. And so this vaccine certainly should not be the golden ticket. I know that demand is far greater than supply. I get that. But we have to talk about distribution sites that make sense, access that makes sense, ongoing. And that's a conversation I know that we have to have.
And because things change daily about this virus, you know, how long do the antibodies stay with you? How long is the vaccine going to work? Does it really work? We don't know enough about the vaccine. So how do we go out and educate people that this vaccine is safe? And I believe it to be safe, but we don't know definitively a lot of these answers.
We have to
So,
trust in science. Oh, I'm sorry, Dr. Clarke, I'll let you go
no,
ahead.
please go ahead, Dr. Landry.
So I think we have to trust in the science. I think that we were all, and I can tell you this as someone working in the emergency department just yesterday, and having these discussions with both my colleagues and also the patients I was caring for. I distinctly remember sitting down, going in to see a gentleman who came in to the emergency department for an issue unrelated to COVID-19. And we sat down and had a quick conversation. And I said, hey, make sure you get your vaccine. And he said, well, I don't know, doc. And so I took that minute, and I didn't have very long to sit down and chat with him. But I took that minute to go back, sit down with him, look him in the eye, and have an honest conversation with him and explain to him what I understand about the study, making sure that I asked questions to him to make sure I understood what he knew about the study, and sort of meeting him where he was, and then trying him to move him towards a position of saying, yes, my job isn't to browbeat these individuals. My job isn't to force a vaccine upon someone. It's to make sure that they are aware and they have the proper information that's accurate and as up to date as I can provide them, and help them to make the decisions that's going to be best for them. I certainly am a proponent of the vaccine. I signed up for it. It was announced on a Tuesday. By Wednesday, I was first in line to get my shot. But I explained to them why I chose to get the shot. And I share my personal story in addition to the data. And when you share your personal story and you share the data, I think you're going to be able to move more people along towards getting towards yes.
Did someone else have a comment here?
Yeah, I would like to add that, as I mentioned, the Black Coalition Against COVID-19 has been doing work. I said since August, that was on the vaccine, but since around getting information out about COVID since last April. And it's a grassroots community organization, community leaders from across multiple disciplines. And we've taken two principles: listening to the community and their concerns, and then what I call a hyper-local approach. So working with the artist community, youth, labor, teachers, to work with trusted messengers from their community, have listening sessions, hear what their concerns about, and then work with them to craft messages for their organizations that they themselves then deliver back to their organizations in a community conversation. And often they're accompanied by public health or healthcare professionals who can be there to support with additional facts and information. We found that extremely effective. We partnered with blackdoctor.org to have large community forums, and sometimes 20,000 people have gotten on. And so we've taken polls, and we've actually seen that vaccine hesitancy has moved to vaccine acceptance. It's gone from 60% among African Americans down to 30%, which is on board with the rest of the population that says about 1 in 3 people are unwilling to take the vaccine. My concern with sticking with that, oh, Black people are vaccine hesitant story, is that when allocations of vaccines need to happen to Black communities, which we've seen, they're getting fewer because the assumption is being made that, oh, they're hesitant, so the demand is not going to be in those communities. We have to start to change that narrative because our community is changing. And even the people who are reluctant, they're saying, we just want an opportunity to talk with somebody and get our questions answered, just like with Dr. Landry and his patient, which is brilliant the way that he approached it. So, I think these kinds of forums are great, and the opportunities to get questions answered are key.
I think you brought up a really great point, that one-on-one discussion or having Zoom sessions like this. And I know there are a lot of people who are concerned about all the different kinds of vaccines. We have 2 mRNA vaccines. We also have the Novavax, AstraZeneca, and Johnson & Johnson, which work differently. When we get the flu vaccine, we don't go in and say, we want that flu vaccine. We know a lot now, but what do we really know about each of these vaccines? Anybody feel comfortable with that one?
I think the science around the newer generation vaccines, the mRNA, is probably thrilling to all of us, scientists on the call. It's really an exciting advancement. That in and of itself, though, I know isn't necessarily comforting for a lot of our communities that, perhaps don't want to necessarily put themselves at risk of trying something new. But I definitely have been advocating, particularly because these newer vaccines, the mRNA vaccines, have a much higher effectiveness. I mean, the data around these vaccines are much more telling than anything that we've seen of the flu vaccines. And I think that's comforting for a lot of the veterans actually that I've been talking to. They like to know that, that there's evidence, and we're sharing that information as much as, they're seeking it out. So it's definitely difficult to think about the fact, though, that certain communities won't necessarily have access to them. And particularly for us, we're thinking about a lot of the rural communities across the country that maybe don't have as much of a distribution coming out. So they may be facing some of the other vaccines. But at the end of it, some vaccine, regardless of which it is better than none. We need some sort of protection out there so that we can hopefully at some point prevent the transmission of this disease.
And I'm glad you brought that up because, I have friends who said, I'm not going to get the Johnson & Johnson vaccine. That's only 70-some% effective, but some effectiveness is better than none.
Exactly.
And let's talk about the veteran community and outreach among veterans.
Thanks for letting me touch on that a little bit. And we're very a different type of health system than I would say the rest of the private sector is. And we've been fortunate enough to really have targeted outreach throughout all of our 170 medical centers around the country. We are purposefully reaching out to veterans who are of those different risk categories. So based on their age, based on different diseases that they may have, our spinal cord injury patients, our dialysis patients. We've been lucky enough, and we're proud to share that actually, like Dr. Clarke showed, our hesitancy rates actually show no difference between white and Black and Latino veterans. And to be honest, they're taking up, our veterans of color are actually taking up the vaccine at sometimes higher rates, depending on the community that we're talking about. We're just looking through this data across the country, but a lot of that, again, is because exactly as we've been saying, targeted outreach, answering their questions, making sure that we're addressing their concerns, not just sitting back and letting them know when the mass vaccinations or appointments are available, but actually reaching out to them to make sure that they are aware of the appointment, that they get a reminder about the appointment. We're being as proactive as possible. I think that may be a little more difficult throughout the rest of the health system, but really, my message to any veterans that might be watching are, indeed, we're here for you. And if there are questions, you may need to wait a little bit based on your risk factors and based on how we're actually distributing the vaccine. But you will be able to get covered and you will have your questions answered.
Well, here's the
Barbara, I just want to go back one, because as an advocate, it was, I remained quiet, and that's typically not my style, but I want to go back to this notion of some vaccine being better than no vaccine. I think as an advocate for our communities, I need to stress that we have to advocate that there be an equal distribution of all vaccines. Or we go right back to this discussion of distrust in our community. We cannot allow for a vaccine that's 60% only to be given to targeted minority communities. And so I'm remiss not to have jumped in at that moment, but certainly part of the job of every advocate is to make sure that there is parity in the distribution of vaccines across the country.
And that's a real concern. I mean, given our history, why wouldn't we get the one that's less effective?
Well, and I think we also need to think about the how the vaccines are stored and how they can effectively be distributed. Because the reality is, as we think about the logistics that may come with a vaccine that has to be stored at an ultra cool temperature compared to those that don't, there may be some places with less resources built in. Obviously, as you can see what happened in my home state of Texas, the infrastructure is just not there from a power grid standpoint to support some of the rural communities that Dr. Matthews was talking about earlier. But but Ms. Watkins is right. We need to make sure that those people who are in those harder to access communities do have access to a safe and effective vaccine. And if not, we're trying to be clear as to why. And it's not to say that, well, you're considered less than, and so therefore you get the weaker of the two. But it's to make sure people have an understanding of what resources are available in each community, what techniques do we have to reach out to those most vulnerable, and how are we trying to make sure that everyone is protected to the best degree.
Could I add on that? I couldn't agree with this point more, that the equitable distribution is so critical. And yes, the rest of all of the different pieces as far as fridges and freezers and other supplies are just as critical. But I think what COVID has pointed out, and what has been so frustrating throughout this pandemic as well too, is the lack of our public health infrastructure around the country, so that we don't necessarily even have, you could send a freezer full of vaccine, but if we don't have nurses, if we don't have an actual support structure in place, which has been decimated in a lot of our Black and brown communities around the country, then those vaccines aren't going to make it into the right arms that they need to. So it's got to be about support staff. It's got to be about building a public health infrastructure so that we can actually respond to this disease.
And since you're from different locations, do you feel like there's a concerted effort to reach out to the Black community to get these vaccines into arms?
Well, I'll tell you, our national headquarters is in Baltimore. I live in Texas. First week of distribution, there was a disturbing headline where vaccines were sent to a wealthy condominium of seniors, and it was delivered to on site for delivery to them, while everyone else scampered to try to get a vaccine, and even now cannot. And so I think even after that, there has been a great opportunity for more people to be engaged. I think, we're very fortunate. We have an African-American mayor who is really pushing this forward, and a lot of local Congress people who are working toward. But I'm in a large urban population. The notion of what happens in rural populations or in smaller populations is still real. And even with that, there is the notion of how do I take off time to do this? Are we going to get past the notion of 9 to 6 in vaccinating? Are we going to go to 24-hour vaccination opportunities? All of those things matter to our community. It has not been so long that I cannot remember being an hourly employee and waiting on my schedule. It's been many years ago. I don't want to count how many, but it is real. And so we have to have a memory in planning for others that will be impacted in a way that we might not remember. And so, as they put together these panels, I only ask that they have people who understand, either have a memory or who are engaged with the community to understand what is best access for us.
Meantime, as this vaccination, and I'm going to say slowly, is making its way out, we're seeing mutations. And that is a problem on top of a problem.
I'd like to take a step back before we talk about the variants and sort of set the table so everybody's on the same page. I've seen a lot of questions in the chat. Number one, just defining how a vaccine works. I call it, for example, if you were going to get a pop quiz and COVID-19 is the pop quiz, and the day before somebody came and gave you the answers to the pop quiz, that's what a vaccine is. It gets your body ready to address the pop quiz and ace it the next day. And then in terms of, mRNA, it sounds very scary in terms of it being genetic material of the virus. But keep in mind, every time you get infected with a virus, the virus, its whole purpose is to get your cell to become a coronavirus factory and make more virus. And the way it does that is it presents its genetic information, which is like the instructions for how to make more virus. So when you start to talk about variants, and they sound very scary too, that's when in the process of your cell becoming a coronavirus factory to make more coronavirus, mistakes are made. And so the spike protein that allows it to latch onto your cell and get in, it becomes in the case of these variants we're concerned about, even stickier. It's able to grab onto your cell and get into it much more efficiently than the original virus. And so I think when you start to talk about things in terms that people understand, it demystifies it and makes it a lot less scarier, because people have taken the word nanotechnology. Nano just means little. The ability to work with technology on a very minute level. It's not something to get 5G into your body, as many of the early conspiracy theories talked about. So when you explain things in a very easy to understand way, I think it demystifies the whole vaccine and allows trust to start to come into the picture.
And it's important to note there is no live virus in these vaccines.
Correct.
Correct. Yeah, the genetic material is just for that spike protein. So it's unable to give you an infection of COVID because it's not the complete virus. It's just that one little piece so that your immune system knows what it looks like, so that when you are exposed to the real thing, it can immediately recognize it and tackle it and take it down.
I don't know how many of you have already gotten both of your vaccines. Probably many of you have gotten one. I hear a lot of bad reports about the second vaccine, and that gets out there. More of the Moderna than the Pfizer. I don't want to call out one over the other, but these are the reports I'm hearing as a reporter.
So I got both of my vaccines.
Yeah, if you look at,
Go ahead, Dr. Clarke.
I was just going to say, if you look at the original data, it's roughly about the same in the trials in terms of the effect of the second vaccine. I've had the second vaccine, and I had Moderna, and I had the fevers and chills and fatigue for about a day and a half. I took Motrin and Tylenol, and I felt fine. But it's actually when you get sick, it's actually your immune system's response. It's not the vaccine or the virus itself. And so that means when you have those effects, that's your immune system ramping up to be ready. And of note, those effects with the second vaccine are more common in people under 55 than in people over 55, because as our immune systems age, they become less robust in their response, less aggressive. So you're less likely to get those effects.
I was actually fortunate enough not to have any effects with my second vaccination. My first one, I had a little bit of chills just that night. It only lasted a couple of hours, so I don't even know if it was caused by that, to be honest. I was a little nervous with the second one, but had absolutely no effects.
It's important to get this information out so people know what not to expect. Maybe go ahead.
Oh, I'm sorry, Ms. Morse. I got both of my vaccines, and it just so happened I got my second vaccine on January 6th, the day of the insurrection and attack on the Capitol building. So maybe my mind was elsewhere, and I didn't pay attention to any side effects as we were watching our country go to a bad place. But I actually turned out pretty well. I had the Pfizer vaccine. But I know this is something that Ms. Watkins is probably going to say, so I don't want to steal her thunder. But I think there's what we're talking about as far as the second vaccine and the side effects and how people feel afterwards. This is less from a distribution of the vaccine standpoint, but more from an understanding that as we are distributing this vaccine and we're thinking about those individuals who are going to be getting the vaccine and then have to go to work the next day. I'm fortunate to be in a position where I could, my hospital was scheduling people so that they were off the following day for their vaccine and they wouldn't have to come into work if they become symptomatic. But as we think about our communities that we're trying to engage, and they're going to try and get their vaccine at 5 o'clock in the evening after they leave their work, and they're expected to be back in the office or factory or at the job or wherever they are at 8 o'clock the next morning, I think we have to have an understanding that there needs to be some leeway from employers to make sure that people can get their vaccine. Because when we talk about reducing barriers to the vaccine, it's not just getting the shot in your arm, it's dealing with the sequelae that may happen with the vaccine. So just a way for us to think about this a little bit deeper, as opposed to just thinking about those first level issues of getting the vaccine, but also what else may come from it.
It's a convenience factor. And I know, Carmen, you probably have something to say.
I was going to let him have it. Thank you, Dr. Landry. You're absolutely correct. And I had the Moderna shot, and the second one took me out. Not to be so blunt, but it took me out. So I can appreciate that. Thank you.
And people want to know, and I'm just diving into some of these questions because they're really good. which vaccine is best to take, Pfizer or Moderna? Does that depend on ethnicity, age, underlying conditions? Are they all equal? I mean, it's probably the $1 million question.
Well, they're all equal, and to the idea of the fact that, you know, I have not reviewed the Johnson & Johnson data because it's not yet available publicly. It's just a press release they've put out. But the concern that it's less effective than the others, keep in mind that it was trialed against the South African variant. And based upon what they say in their press release, after about 28 days, it's 100% effective in preventing death. And after 49 days, it's 100% effective in preventing severe COVID. So when people say it's better to get some protection than no protection, it's true. If all of them appear to prevent what we don't want, which is severe COVID and death. Some people might get mild to moderate disease where they can treat themselves at home despite getting the vaccine. And that's a win because we're looking at 500,000 deaths. We don't want that anymore. We're looking at over 65,000 deaths of Black people. We don't want death anymore. And so, you know, it's important, you know, as you're talking about these, you know, should I get this one? Should I get that one? It really doesn't matter because they all prevent what we don't want.
Yeah, and full disclosure, my dad died of COVID last year. I'm a big supporter of the vaccine. In fact, I'm taking part in the Novavax vaccine trial because we had to watch him die from afar. So when you say 500,000 deaths, those are people. Those are real people. Yeah. And those are Black lives. And, you know, Black lives always matter, but, you know, when it becomes personal, I mean, you need to take action. You need to be proactive.
Yes. And I'm sorry for your loss. I have had loss of friends and family, and, you know, my heart goes out to you. And I'm really glad that we have an administration now that's recognizing that each of these people are souls and honoring them in that way. It's high time that we do that. At Black Coalition Against COVID, we focus on the DC area. So we had a remembrance ceremony pretty early on, around August or so, for those people in the DC area where people were allowed to come on to the radio. We work with 2 radio stations and simulcasted, and they could come on and tell their stories about their loved ones. And that was very cathartic. And we haven't even touched on the mental health aspects of what all this is costing us as a society and how to move forward from that. But just acknowledging it is a big step.
Yeah, mental health is a huge issue. I've done so many stories on that as well, because it does affect you mentally. And a lot of times we don't want to talk about it. You know, it's over, it's done. But somebody wants to know, has it been considered to reach out to religious leaders to educate them? We know the Black church is very powerful. You know, reaching out to the religious leaders, to churches.
I think we have to move toward that. I still think what's happening, though, in so many communities across the country, the Black church as we know it is not assembling in person. And not to say that you still can't do this same outreach virtually, because you can. We are a touchy-feely people. So we have to use every avenue that we have to make sure that we get this information out. It's a great idea. I hope that we...
And I hope that you all enjoy the rest of your day and stay safe. Thank you all very much.
Thank you for having us.
Thank you very much.
Thank you.
Everyone.
Have a good night, everyone. Bye-bye.
Hey, Evan.
Coalition Against COVID-19. Since May, they have stood up something called the Virtual Health Ministry. 4 of their churches are doing calls to all their congregants to assess, to understand what needs they have around social services and health. And then they're bridging them to people at Howard University in the Department of Social Work and at the Department of Family and Community Medicine at the hospital to ensure that their needs are getting met. And some of those sites, the Black church is stepping up to the plate. Some of those churches, which are vacant, are now becoming COVID-19 testing sites and COVID-19 vaccine distribution points. And the community is loving it and embracing it because they feel like they're going somewhere trusted to get their vaccine, and they have lines, there are people waiting to get vaccines at churches. And that's a movement that's spreading across the country, not just here in DC.
Barbara, Barbara, I saw a question, and I hope you don't mind that.
No, you go for it, girl.
Does it cost? Can they get vaccines at no cost? And
Yes.
there's already been folks who are trying to rip off our community. All these vaccines are no cost. They may ask who your insurance company is, but certainly it's not charged to your insurance company. I don't even think you have to provide a number. I know you don't. And so don't let someone tell you that there's a cost affixed to getting a vaccine. That is not true. And that's one of the mistruths we have to get out into our community.
And I just want to say something that Dr. Clarke and Ms. Watkins were both talking about earlier. Just I think we need to sort of pause on this discussion and really think about what this means. So the Black community is resilient. Our churches have stepped up and done amazing work. And we've thought about this issue around vaccine distribution and engaging our communities in such a novel way that hasn't been tapped in before. But one of the things that's happening is these are people who are coming at this with really good intentions and doing great work that's fact-based and from an informational standpoint, but they're under-resourced. And as we think about how we can do a better job of being more equitable in the work going forward, we should take from these lessons learned and figure out how we can reinvest in communities, specifically supporting churches and community organizations who are doing the work that, as Dr. Matthews mentioned, wouldn't be necessary if we had a stronger public health infrastructure in our country. And so we're asking our churches, we're asking our community leaders to do work that our government should have been doing in the past, but they're not. So let's make sure that we're supporting those communities, those individuals who are actually leading, as opposed to expecting them to do this on their own free time.
But you also have to ensure that the vaccine is there, and we're seeing shortfalls. In Rhode Island, people are trying to sign up, then it's cut off by 11 in the morning, then they're trying to sign up the next day. So you can bring a horse to water. You know, it's just getting that vaccine into arms because of the shortfalls.
You know, I think that there, you know, I said before, demand far outweighs supply. And I hope that over the next month or so, we see those two things begin to normalize in such a way that people have access. But I do believe a portion of those vaccines have to be set aside for walk-ins, because there is the inability for some to schedule. And even if that is, 500 shots, a week, they have to be available for those who can walk through and get them at will. And it's going to take us some time. But as we roll out more vaccines, I know the numbers will increase, and then we'll have access for all that want to have the vaccine.
And we always hear about those extra doses that pharmacists can squeeze out of those vials that they sometimes throw away, but if you show up, they might give it to you.
You know, it's interesting. Dr. Matthews and I have a colleague who is also a physician who missed out on the first round that his institution was providing. And when he pointed out the reserves that were left in the vials, they actually reconsidered the entire process and made sure that he and a number of his colleagues got their vaccine. So I think there's something to be said about that. As we think about how vaccines are distributed, where they're held, obviously, we need to do better as far as infrastructure and vaccine distribution, and making sure that we have functioning websites that are up and available, but we also equip our community health centers and our PCP offices to make sure that those vaccines are available, and making sure that people who need the vaccine are able to get it. I think it was Ms. Watkins who mentioned earlier about having multiple computers going and a telephone going, looking to schedule a vaccine for her mother. I'm hearing stories of similar situations, and there's this whole concept that we probably need to unpack a little bit more, called vaccine tourism, where people are going into underserved communities that have access to the vaccine. They're coming from well-resourced communities, and they're going into those under-resourced communities and getting vaccines and then leaving. And the reason they're able to do so is because they have the wherewithal, they have the infrastructure, they have the ability to access technology. And so if we're relying solely on the internet and these websites continuously crash, as what happened here in Massachusetts when they unrolled the vaccine, then we're going to clearly miss out on people who don't have access to broadband internet or Wi-Fi. I mean, we think about this. We have students that are sitting in parking lots of restaurants and fast food restaurants to do their homework. What do you think is happening at home for those parents who may need their vaccine? So if we're solely relying on the internet to get these vaccines out, we're not going to get to these communities that are going to be most likely to succumb to the sequelae of this disease. We need to be using phone banks. We need to be proactive in reaching out to those individuals and scheduling them as opposed to having them call us. We need to be using all this novel technology that we have, but then also go back to the basics. And what worked in the past may actually work now. And let's figure out how we can use some of those older techniques that may still be viable.
Mm-hmm. How important is that second vaccine? We know that Johnson & Johnson is one, but the others are all 2 vaccines. Is it enough to get one?
I think that we have to, when we say trust the science, we have to go with the science. And the scientific process was the clinical trial. And the clinical trial showed that you get the 94 to 95% efficacy after 2 doses. And so, we're seeing, yes, with the first vaccination that they're seeing up to 84, 85% efficacy, but we don't know how soon that falls off. The whole purpose of the second dose is to wake up the memory part of your immune system, the part that remembers long into the future, should you come into contact with the coronavirus several months down the line, that your body will remember it and how to react to it. So I would be very hesitant to cut off and say, yeah, just stick with one because it's easy. I think we should really focus on getting everyone 2 doses as much as possible.
Let's say you can't make your
Moderna.
Let's say you can't make the 3 or 4 week. It depends on the vaccine, the mRNA vaccine you took.
Yeah.
Is it okay to get it several months out? We're working, we're busy, we missed our appointment.
So the official recommendation is don't wait more than 6 weeks, 42 days. But again, I think that if you have an opportunity to get the second dose and that time has passed, it's most important to get the second dose.
And a lot of people have a lot of questions about how long these vaccines last. We haven't had these clinical trials, not even a year on the COVID-19. So how long did they last? How long are the antibodies with you? We hear people who've had COVID-19, 6 months later, they don't have antibodies anymore. There's so much not known about getting it naturally or even the vaccine.
I think that's unfortunately why this is such a difficult conversation, because there's still a lot that we don't know. We still don't know a lot about the virus, how the vaccines are going to be protecting us over time. I think we're doing our part currently, right? We're talking about the importance of protecting ourselves. I hope we can also talk about, the other measures that are equally as necessary with vaccine, right? Continuing to wear your mask, continuing to physical distance, all of it is necessary, not just one piece. But until we have those answers, we need to continue together to at least use the solutions that we know about, and then share the information as we do have the answers to those questions eventually. Unfortunately, we don't have them currently.
And that's a good point that you brought up, that we need to continue to social distance and wear our masks even after vaccination. We need to reach herd immunity, which is about 70 to 80% of the population. And that's going to probably not be until this fall.
Yeah, I think what Dr. Clarke mentioned earlier is the critical piece. The vaccine protects against death and severe disease. It does not protect against transmission. So you can still pass it on. You can still receive it even after you've received the vaccine. So we need to be careful about that. We need to love our neighbors and, stay separate just a little bit longer. It's been a difficult year. I'm so glad we mentioned the mental health piece, particularly for veterans and the social isolation that we're seeing having an impact on a lot of their mental health. This is a difficult time. And I think, if we recognize that we're all in this together, and while we're distancing, there's still different ways to connect. Hopefully we can really get through this on the other side without having as much impact. But we still need to stay separate because unfortunately we can still pass on that virus even with the vaccine.
But pandemic fatigue is real. Go ahead, Carmen. Or Dr. Who was talking?
No, it was me.
Dr. Clarke. Hi.
I think it's important to mention though that, it is an altruistic reason to get the vaccine so that we can all get to herd immunity. But immediately within your family or your set of girlfriends or friends, once you all are all vaccinated, it is okay for you all to get together. And that's one very important reason. I have a friend who's 70 who her girlfriends had all gotten vaccinated, and she was, hesitant about getting vaccinated. And when she realized that they were all vaccinated, they could all get together, she said, oh, wait a minute, I guess I need to get it too. So that's actually an important thing to keep in mind, that, you can start to get together with your other friends and family who are vaccinated if you haven't been able to do so far.
Well, one thing that I'm gleaning from that we're getting so many emails about people are jumping the line. That person was only 60 and got it. I'm 72. How do you address this out in the community?
There's actually, every state has a different protocol. I know in Texas, if you are 65 or less than 65, but you have underlying conditions at this point, you can still get the vaccine. And so I think you have to make sure that as you look at who's who and who's getting what, you're looking at what the standard is for your local community. That is not to say that there will not be some golden tickets given out because of class and access. That's real. That's exactly what I spoke of earlier, where the 100 or 90 vaccines were sent directly to a retirement community where, the average house was 500, but the average condominium was 500,000 plus. So that's real. But that does not stop us for advocating for access for our community. That does not stop us for not only getting the vaccine ourselves, but helping others access the process. And make sure that they are vaccinated if they're willing to do so. And I think that's the responsibility that each of us share as we do this work.
What about pregnant women in the vaccine? We know they're starting clinical trials on pregnant women, but not a lot is known, and people are worried about birth defects. But from what I'm also hearing, and probably any of the doctors can chime in on this, it's worse for a pregnant woman to get COVID-19.
Yeah, pregnant women are at greater risk for blood clots because of their pregnancy. And anytime a pregnant woman gets a high fever, she is also, there's a risk to the baby as well that she's carrying. So for that reason, even though pregnant women were not included in the original clinical trials, a lot of OBGYNs are having one-on-one conversations with their patients and advising them to go ahead and get the vaccination, because they know that the effects of getting COVID-19 for a pregnant woman outweigh any risk from the vaccination. There's also a rumor going around in social media, which I just have to stop right here for a second and say, a lot of people don't realize that the same Russian bots and trolls that interfered with the 2016 election have been targeting our communities with vaccine misinformation since that time. It started off with the flu vaccine, and then when COVID came around, it just switched over to the COVID vaccine. And that's information out of the University of Maryland Center for Health Equity, if anybody wants to read more about it. But one of the rumors is that the spike protein is similar to the protein that causes the placenta to bind to the uterus. And so therefore an autoimmune reaction happens and starts to attack that, that lining. That's absolutely not what we've seen. It doesn't happen in real life. There are certainly many women who were in the original clinical trial with Pfizer and Moderna that got pregnant during and after and are, still pregnant. And so there is no basis to that rumor or cause for concern that it causes fertility problems.
Yeah, there have been a lot of myths out there circulating, and that's where, we need to get more education out there and just educate ourselves, I guess. There's been discussion about mixing and matching the shots. So you can get possibly the Pfizer for your first dose and possibly the Moderna for your second. Any thoughts on that, given some shortages in facilities and getting some of the vaccine out?
So, that's a great discussion that is out there. And I think what we have to go back to is we're having conversations that we're trying to root in science. We're trying to have a conversation around the importance of uptake of the vaccine and proving that it's safe and effective against the vaccine. So if we try and come up with these novel techniques and approaches to doing so, then we're stepping away from what the science has done, and we're moving away from what the studies have shown. And I think in order for us to be honest in these conversations and be trustworthy, we have to stick to what we know and stick to the science. And so others may disagree. However, I say if we're going to be true to ourselves and true to the science, then we have to say we don't know, and therefore we shouldn't be advocating for something that is outside the purview of what we know. And so you should be getting, if you get one, you should get the second one of that same variety. You shouldn't be crossing over to different brands of vaccine. We just don't know because we don't have the science. And just like we were talking about earlier, Dr. Clarke mentioned about how long you should go with the vaccine, or if getting one is okay and not getting the second. The studies were designed specifically to look at people who got the vaccine after 3 weeks for Pfizer, 4 weeks for Moderna. We know that science is what was required. The vaccines are effective when taken that route. We don't know if a single dose will be as effective as we'd like it to be. So therefore, if we have these conversations, we have it in a fact-based, matter-of-fact perspective, not with a lot of variety, and giving people options for choosing one and then getting a second at a different time.
Is it encouraging? Did someone else want to say something?
Nope, just agree.
Oh, is it encouraging that a lot of people got the flu vaccine this year? We were masked, we were social distance, and our flu rates dropped dramatically. Is that a signal that the COVID-19 vaccine can replicate that?
I would say no. I would say that's a sign that we have, when we wear masks and socially distance and wash our hands, we can prevent the communicable spread of disease. As a practicing EM physician, I have seen 0 cases of the flu, where this time last year and years before, I would have admitted dozens of people to the hospital, and I would have had multiple patients who have died from complications related to the flu. However, the fact that we're socially distancing, we're washing our hands, and we're wearing masks means that in addition to people getting the flu vaccine, when we do those other public health matters, we prevent the spread of disease.
I think that's excellently said. And I also want to add to that, though, the efficacy of vaccines. Israel is one of the countries that's vaccinated a good percent of their population, I think pushing 50% now. And they've been doing studies to see how effective vaccinating the COVID vaccine specifically. They've been seeing that among healthcare workers, COVID infections, so testing positive for COVID, has dropped by 85%. So we know historically that vaccines are effective, right? And we now are beginning to get the first evidence on a mass vaccination level around COVID.
We are seeing that in portions of our own health system, and are looking to get that published as quick as possible as well too. We're very hopeful about limitations on transmission with this vaccine. It's working. I think there's larger conversations about continuing the other public health solutions, but the vaccine itself is working. But of course, the larger conversation we're having today is how do we make sure it's equitably distributed. But otherwise, the communities where there is increased vaccination, it is working.
Somebody wants to know about genetically. Does this vaccine work differently in African Americans and white people? Are there we know we have genetic differences.
Actually, there is no such thing as race.
Yeah.
On a genetic level, we are 99.9% the same. And people of African descent actually have the greatest amount of variation among us because we have been on the planet the longest, right? So the longer you exist as a community, the more variation in your DNA pops up. So there potentially is the same amount of genetic similarity between any given European and any given African than there is between two Africans, say one from East Africa and one from West Africa. So that being said, the reason why we make a big deal about having diverse populations in vaccine trials is not necessarily because we're concerned necessarily about the genetic difference between any given one black person and any given one white person, but the social and environmental conditions under which we live can cause a different level of activation in certain genes. And so therefore, it's important to have people of various cultures, various ethnicities, various life experiences, various ages and genders to ensure that the vaccine results that we get are uniform across a big swath of people. And if there are differences, we can try to understand, well, what are the factors that are leading to those differences? But genetically, we are one human family.
You answered artist's questions, so I appreciate that. Does it help to be well hydrated before getting the vaccine? They talk about don't take ibuprofen before getting the vaccine. You know, there seems to be some do's and don'ts out there.
So go ahead, Dr. Matthews.
I was going to be a little flip and say it's actually important to be hydrated all the time.
Correct. I agree with that.
But, you know, I think some of the immune reaction could be, again, a fever, a chills, and you may be more likely to perspire and have other immune reactions. And so, yes, being hydrated prior to the vaccine, prior to any effects coming on, might be helpful, but I wouldn't necessarily think that and in fact, we have no evidence that it is preventing side effects.
But the ibuprofen I'm hearing you should not be taking during a vaccine. Is that true or false?
I have not seen any evidence of that. Any others?
So there was a theoretical paper that was published around other vaccines in the past that say that if you take acetaminophen or Tylenol or Advil, Motrin, ibuprofen, they're all the same thing. You know, those three things are the same thing, that it can blunt your immune response. And so the papers that I read said, if you're going to take it 4 hours after the shot, and only take it if you are having symptoms. So there was a whole discussion about, you know, whether you should take it just in anticipation of the fact that you're going to feel sick. And they say, no, don't do that. Wait until you actually have an effect. And then if you have the effect, make sure that you're taking it 4 hours after you got the shot.
I'm also reading about avoiding a mammogram for like a month after getting the vaccine because of the inflammation. These are things that I think it came out from the CDC. You can correct me, but this came out recently.
Yeah, this is from the Society of the Doctors that read mammograms. And so, you know, everybody's into their own thing, right?
Right.
So what they said is, in the arm where you got the vaccine, some women or some people are experiencing lymph node swelling or swollen glands underneath that arm. It's a possible side effect of any vaccination, and it happens rarely, and it goes away in a few days. But when you get a mammogram, if they see those swollen glands under there, they don't know whether it's due to a vaccine or whether it's due to cancer. So it's making it more difficult for them to read the mammogram. So their society has come out and asked people, look, either if your woman gets your mammogram before you get your COVID vaccine, or if you get the COVID vaccine, wait for a month before you get your mammogram.
We're learning something every day, aren't we?
Yeah.
What about people with autoimmune disorders? Kenya has that question. Is it safe?
It is safe. At this point, really the main contraindications or reasons why you can't have the vaccine are whether you have a known allergy to it, although how would any of us know this at that point? Otherwise, really the risk factors, again, of having COVID-19 itself are much greater, and having severe, if not, the worst outcome of COVID-19 are more severe. So no, we're still recommending that patients receive the vaccine with autoimmune disease.
And someone, go ahead, doctor.
Well, I just wanted to say, there was this discussion that was happening very early on when the vaccines were being rolled out. And every time someone stubbed their toe after getting the vaccine, it was reported on the news.
Yeah.
And I think that is sort of an injustice that is being done towards these vaccines. Because if you look at the data has proven that these vaccines time and time again are safe. And yet we were so hyper focused on, is there going to be something bad that's going to happen? And I think we should have changed the perspective and said, if we don't get these vaccines, what else bad is going to happen to our communities? What else bad is going to happen to these individuals? Because the reality is, the longer we let this play out, the longer it takes for us to get more into our routine as far as, and I'm specifically saying this related to healthcare. Think about all those individuals who were in line to get their endoscopies or their colonoscopies or those mammograms, or other parts of their preventative health screenings that they would have typically gotten. The fact that so many of these tests have been pushed back for a year and will be pushed back even further as we try and catch up to those backlogs means that we're going to have higher rates of those individuals being diagnosed with cancer when we could have caught it as a polyp, when that nodule on the breast could have been biopsied and treated early, but is now going to be metastatic or spread to other parts of the body. So the reality is we need to change the framing of this discussion and say, yes, we understand that there are risks that come along with the vaccine, as with every medication. However, if we don't get back to our routine, traditional preventative medicine approaches, then we're going to have other deaths, unnecessary deaths that could have been preventable and avoidable had we not gotten, had we done a better job of getting people better vaccinated.
Yeah,
I can agree with. Oh,
yeah,
sorry.
especially those screening mammograms and colonoscopies. I mean, African Americans have a 20% higher risk of getting colorectal cancer and a 40% higher risk of dying from colorectal cancer. So when we let that go because we're too afraid to go in, then we're putting ourselves at further risk.
Can I just say there are questions about individual diseases like sickle cell disease, autoimmune disease, diabetes. It is safe for each of those people who may have those pre-existing conditions to get the vaccine. There's no increased concern if you have a pre-existing condition. As a matter of fact, people with chronic diseases in the trial, again, it was 94 to 95% effective in those groups. And those groups who have underlying conditions like sickle cell are at the highest risk of getting hospitalized and dying and having long COVID. So it is very important, just as Dr. Landry said, what happens if you don't take the vaccine is much worse than if you take it.
And you just answered somebody's question. Someone wants to know if you can dissect that 85% number for testing positive decrease. Is that a general number across all cases or segmented by race? I'm not sure about the 85% number for testing positive decrease.
What's the
ring a
question
bell?
again? I didn't understand.
Could you
Maybe they didn't get
repeat
it.
the question, please?
It's the question reads verbatim. Could you dissect that 85% number for testing positive decrease? Is that
I think they might be talking about what I said in Israel. I think I said 85% decrease. Yes. So there are 85% fewer cases of coronavirus in Israel among the groups of healthcare workers. They looked at 7,000 healthcare workers that had been vaccinated. So that's what the 85% decrease in the rate of cases referred to.
Okay. And are people automatically scheduled for their second vaccine when they go in for their first? Is that protocol?
I think
They're supposed to be, but you're going to have to be vigilant.
Yeah.
I just want to be, you're going to have to be vigilant about your second dose and about it being done on time.
I would say everyone should ask
Yeah.
to get their second dose scheduled before they leave the vaccination site, or understand, are you gonna call me? Are you gonna text me? Are you gonna email me? Do you have my correct information? Make sure that that's done before you step foot out of where you got vaccinated.
And 3 to 4 days before that date, you make sure that you're calling to make sure that that appointment is correct and done.
Now, people get the vaccine cards. Is that right across the board? Did you all you got vaccine cards?
Yes.
Yes.
Somebody wants to know if you're going to need those vaccine cards, will they be required to enter certain establishments? Is that something that's being talked about out there?
I know I read one article that kind of discussed that possibility. I think it's still a bit of an unknown. You can imagine there'd be a lot of coordination necessary for that to happen. But I think again, the more important part is that you keep that document, you share it with your primary care provider, and that indeed you're encouraging others to follow along with you. What we need to do in the future with regard to travel, when indeed we're doing that at larger rates, is all going to be dependent on really our rates of infection and how the pandemic is moving forward. And obviously the vaccine is one way that we can address that. So it's a possibility. I don't think it's something necessarily that should prevent us from, or even encourage us, to be honest, to move forward with the vaccine, since that card itself, it might get lost, it might get damaged in some way. We're encouraging all of our patients to take pictures of it, of course, not post it online because it has your personal information on it. But otherwise, I think that's still that policy focus about travel is still unknown.
So I think it's important to mention too, in addition to that, that there is a precedent for requiring vaccinations to enter certain countries. So we know that precedent is out there already for things like hepatitis B or yellow fever. And then within the other question people often have are, will it keep me from getting a job? Employers are within their rights. I mean, we experience it in healthcare, where if you're going to be in a patient facing position that you have to get, for example, the flu vaccine. But there are exceptions that can be granted in those instances. I don't think in terms of public spaces, just moving around society, that will be able to be, it's just not practical. I can't really see that being enacted, but certainly for employment and travel, we have precedent. And so that might be the case. We don't know yet.
How do we track how long this vaccine works? Do we get tested in 6 months? Do we, because that question has not been answered. Is it 6 months? Is the vaccine going to last a year? Is it a lifetime? And how do we know?
And I think that just goes back to the science and doubling down on the importance of looking at these studies, both short and long term. We know that in the short term that these vaccines are safe, and we know that they work. The onus is definitely on the government and the FDA to ensure that these companies that are producing the vaccines continue to monitor the efficacy of these vaccines in a long-term perspective, so that we can know whether or not we will need a booster vaccine in a year or 3 years or 5 years or whatever it may be. Coronaviruses are not new. This variant being so deadly is what is new. COVID-19 is, we have coronaviruses that are in circulating in society that have not caused pandemics, but we may have future variants of COVID viruses that are deadly. And we need to see, are these vaccines going to be effective against those, or do we need a booster in a year like we do with the flu shot, or with other vaccines, do we need to get every 10 years like a tetanus vaccine? This is something that we just need to continue to monitor and trust in the science.
And I know Dr. Clarke explained how an mRNA vaccine works. How did the other three work? I'm understanding they're like a flu shot kind of setup and not an mRNA.
So the Johnson & Johnson and AstraZeneca vaccines use DNA as opposed to messenger RNA. It's another type of genetic material, same thing. It's the master blueprint, so it gives instructions. The Pfizer and Moderna vaccine get the genetic information into your body using a fat droplet. The Johnson & Johnson and AstraZeneca use a deactivated or dead adenovirus, which is a different kind of virus. It's the kind that causes the common cold. And they put the coronavirus information inside that hollowed out cold virus, and that's what's delivered. And then finally, the Novavax vaccine, which they have partnered, Howard University and Morehouse are two sites that they have partnered with to get their trials done, hoping to get an even broader representation of folks from the African-American community. Their vaccine doesn't involve genetic material at all. It's just the spike protein. And so that's a third way. And again, none of them can cause coronavirus infection because it's only a very small portion of either the genetic material of the virus or the spike protein itself.
And can you explain the difference between emergency use approval and a full approval? It seems with the emergency use approval, everybody's able to get it in sequence, you know, starting from older to younger, depending on where you live.
Sure, it's actually the same review process. It's the same kind of stringency of looking at the science and looking at the data. The emergency use approval was just a shortened time frame. In order to get that process done, the FDA was able to prioritize, obviously, the focus on this vaccine and move forward. The EUAs also have a very narrow approval range, meaning kind of what the company applied for that vaccine is very narrow. It's really actually more of a policy difference, the EUA versus the full approval. It is not in any way a sign that there's a difference in the effectiveness in the vaccine versus if it had gone through the full process. It's really just a shortened time frame.
Okay, because some people are like, I want to wait till it's fully approved and not just for emergency use.
Yeah.
Let's say you've had COVID in the past. You might have tested positive, were asymptomatic, or you had symptoms. Should you also get the COVID-19 vaccine?
Definitely. I think I've had colleagues who tested positive for COVID-19 early on in the pandemic, and they received their vaccine. Again, that we know that we don't know if there's prolonged immunity from individuals who have contracted the virus. The assumption is that there will be some carried over immunity that comes along with that. But we would hope that having that added booster with the vaccine will help your immune system to stay aware and recognize that when that virus does enter your system, how to fight it off. We do know that there are some cases where individuals who caught coronavirus once do catch it a second time. It's relatively small as far as the data that we have, but it is possible. So if you've had coronavirus, you were infected early on, it's definitely reasonable for you to get the vaccine at this stage.
What about children? I believe it's Moderna that is now studying adolescents 12 to 17 for its vaccine. But when does it get to the younger ones? And when will it get to the 12 to 16-year-olds? And we know that they cannot do a placebo arm if you're testing children or having them in a clinical trial. Let me get this wordology right. They have to give you the actual vaccine, but what they're looking at is your response to the vaccine and any side effects.
So they're enrolling children now in clinical trials, and it's estimated that by around September there should be some results regarding these trials. The current trials for Pfizer went down to age 16, so anybody 16 and older can get the Pfizer vaccine. For Moderna, they stopped at 18, so anybody 18 and older can get that vaccine.
But we should maybe by the fall, when kids start going back to school, maybe see a vaccine approved for kids as young as what? I mean, the flu shot can go down to, you're gonna have to correct me here. What, you can 6 months or older, a year or older for the flu vaccine?
Mm-hmm.
6 months, yeah. 6 months.
So do you think that will happen with children as well?
I think we'll have to wait and see what the manufacturers, what their data shows. At this point, I don't think any of us can speak to what the current trials, what the current enrollment is going to show us.
What about community health centers partnering with pharmacies to get the vaccines out in the community?
It's a critical piece. I used to work at multiple community health centers actually before I came to VA, and I know reaching a lot of the communities where I worked on the west and south sides of Chicago, these were oftentimes the only primary care practices of any kind in those communities. And I think we did a lot to earn the trust of our communities. So having those conversations about this vaccine, about the pandemic, about their healthcare in general was pretty critical. So yes, a lot of community health centers also have pharmacies within their walls. So working with either their own internal pharmacy, the Department of Public Health, if there one exists in that community, I think are critical partnerships.
And that's actually already happening. One of the first entities in DC to get vaccines directly, not even partnered with pharmacies, were the federally qualified health centers. And they are, for example, one federally qualified health center is specifically tasked with vaccinating individuals who are homeless, and others are partnered with other community-based entities to make sure that the vaccines are getting out, as well as to their own populations. The key, though, is a point that Dr. Matthews made early on, is to ensure that, you know, these community-based health centers oftentimes have very tight budgets.
Yeah.
And to give them a bunch of vaccines and say, here, have at it, you know, vaccinate all these other people outside of your own population strains their resources. So ensuring that they have enough resources to be able to administer the vaccine and not just giving them the vaccine and say, do it.
Yeah. And that can be a problem, getting the people to administer it. In some places, they have the National Guard trained to do it, or they'll take nurses from different facilities. But that is a problem as well. Carmen, are there any concerted grassroots or media campaign efforts by the NAACP, or maybe you can even talk to the Urban League to get the word out about the importance of vaccine?
Yeah, there's been maybe over the past year, a number of town halls when we entered this pandemic, to address the issues, many issues surrounding the pandemic. And as we move toward this notion of ensuring our community has access to vaccines, we'll continue those partnerships, not only with the Urban League, with NAN, with other groups, with churches, with the Divine Nine and others, to make sure that there is engagement at all levels in our community. And so we'll be leading an effort that we'll be rolling out in the next month or so to make sure that communities of color have both distribution points and access and information as we move through this pandemic.
I think
and I do, go ahead, Dr. Clarke.
I'm sorry, I was just going to say, I think that partnership among organizations is huge. Just as you've done this today, it increases your reach. I'm going to be in a webinar next week with all the Divine Nine sororities and the Links and other Black female organizations talking about COVID vaccines and women's health. And certainly Black Coalition Against COVID-19 has partnered with the Urban League and others, with the four historically Black colleges and universities that have medical schools, to also do lots of joint events to really broaden the reach.
And I have to imagine that mental health will be a big part of the conversation.
Yes.
Yes. Absolutely.
What I'd like to do is go to each of our panelists with some parting words, your message you want to get out, what people should know, what people should walk away with from this conversation. We'll start with you, Dr. Clarke.
I would just like to say something that I said earlier, but I just want to highlight that as African Americans, our key to survival in this country has been to be resilient and to be pragmatic. And in the face of this pandemic where we've lost so many, we really have to weigh the facts when it comes to, is it better for me to take a chance and end up with COVID versus getting a vaccine that is day by day proving to show that it is effective in helping us? And I just hope that as you consider those facts, that you'll turn to somebody who's trusted, that you'll go to the resources that are out there. The Black Coalition Against COVID-19. I have a streaming show every Monday night where I answer questions live, to your clergy, to your doctor, and have those conversations so that you can get your questions answered, because this is literally a life and death decision.
Dr. Landry?
I think Dr. Clarke made a wonderful message just then. I would echo many of the points that she made. I would also double down on the fact that the vaccine is safe and effective. We are all here on this panel and have received the vaccine, and we are not jokingly saying this. We don't have 5G chips in our arms, and we're not being followed by the FBI at this time. So I can say that the vaccine is safe. It works. I am in the emergency department on a weekly basis, multiple times a week, taking care of patients with COVID. And I feel much more safe being in that environment now than I did 6 months ago when we did not have the vaccine. I would encourage everyone to think about how to make sure that our resources are distributed in an equitable fashion, and making sure that that we watch the language that we use around the vaccine, and watch the language we use around the communities that haven't received the vaccine, because it's not that we are not interested in the vaccine or we're hesitant. It's that we haven't been treated justly by the healthcare system in the past, and we continue to have those abuses directed towards us going forward. But we want to receive the vaccine, and so let's make sure that those communities do have access to what they need in order to be healthy and safe.
Words matter, right?
Very much so.
Okay, Dr. Matthews.
I really appreciated the conversation today. I think my parting words are really more coming from kind of my primary care experiences within the VA, and also what I'm hearing from a lot of colleagues around the country. We touched on it a little bit, but I wanted to drive it home that during this pandemic, we have seen a significant proportion of care that we're calling deferred care because of fear of exposure, because of just nervousness about, of course, being around other people. I mean, of course, the messages that we're physically distancing, our communities aren't coming in for those services that are so critical, whether it's your breast cancer screening, your colon cancer screening, two diseases that impact Black people at higher rates. But let's also think about your chronic disease. People's diabetes are uncontrolled, hypertension, other issues. I would just really hope that we could think about the vaccine, think about ways to protect ourselves, of course, wearing the mask, but come in and see your doctor. We need to be able to take care of you. We also need you. I mean, I'm sure, Dr. Landry, you can speak to the fact that it's just been a different range of people coming into the emergency rooms. We know that there's decreased utilization. There's also decreased surgeries that are occurring, and particularly in a lot of our hospitals in the VA, because people aren't seeking out care. They're sitting at home, not wanting to get exposed, completely rational, but foregoing other care. So I'd really like to impress upon the audience that, you know, as much as, yes, we've been discussing reasonable issues with regard to trust for the healthcare system, at the same time, please seek out a doctor, please seek out some advice or concern if you have a medical illness, because COVID alone is not the only disease out there right now that's impacting us.
And Dr. Landry, you can back that up.
100% agree. You know, it's amazing, unfortunately, what we're seeing coming to the emergency department and delayed care. You know, individuals coming in with poorly controlled diabetes, their numbers are through the roof, requiring them to be admitted to the hospital. Individuals coming to the emergency department 3 or 4 days after having a heart attack because they were concerned about getting infected with COVID if they were in the hospital. Missed cases of appendicitis leading to rupture and prolonged complications related to that. So I encourage everyone, you know, go through your primary care doctor, use urgent cares that are safe, come to the emergency department if you need us. Unfortunately, otherwise, you could have worse outcomes if you delay seeking care.
Okay, and Carmen.
Absolutely. So as an association, we have not taken a position for or against vaccines, but this is what we will say to you. We want to provide the best possible information that we can to our communities, A, about the vaccine, B, about its distribution. And we're going to ask that trusted folks in our communities do the same. Don't spread misinformation. What our community has suffered for many years historically is misinformation and misuse. And so we want to go into this process providing some safe shelter for those who have not yet made a decision, hoping that they will, and then provide advocacy for those who have made a decision to make sure that they get the access that they need to the vaccine and the long-term physical and mental health that they need to make it through this pandemic. So it's going to be incumbent upon all of us through dialogues like this, dialogues in our churches and our families, to make sure that we protect ourselves against this pandemic.
What are some of the trusted resources that people can turn to? Somebody wants to know that, and if you can just, I know you've said a few of them, Dr. Clarke.
So I
Yeah.
think
I think that
Landry?
we provided our FAQ to this group, and they'll put the information that we have on the screen so that you can certainly go to it. If not, you can go to NAACP.org and look through the resources, and it's there. We have a host of past town halls, that you can view. And actually, there's one coming up this week on the 24th with physicians to address the same information.
Dr. Clarke or Landry? Or Matthews?
I was going to say the Black Coalition Against COVID.org has a repository of all our past town halls, frequently asked questions, a video that we did as Black health professionals, the love letter to the Black community, all residing on the Black Coalition Against COVID-19's website. And I think I also mentioned to you, well, actually, you can go to your state and local health department website and the CDC, also very important sources of up-to-date information, especially if you want to know about vaccine distribution. You can sign up there to get in your local health department to get alerts as to when they're going to be opening up new batches of vaccines. It works differently in every community, but that might be a place to start. And then finally, as I mentioned, I have a streaming show every Monday night, Dr. Melissa Clarke on YouTube and Facebook. If anybody wants to join and get their questions answered there live as well.
Yeah, and we do have a bunch of the resources on your screen right now. I really appreciate all your time and your insight. I appreciate you, Ms. Carmen Watkins, Dr. Landry, Dr. Matthews, and Dr. Clarke for your time today.